going into the future, so all of you are going to walk out with fantastic dental health. That's my gift to you. After lunch, you'll have fantastic dental health. That's the future. Anyhow, we're in for a real treat. I've known Dan since 1973. We started working professionally together. We met, and he started referring patients to my office, and I have had no one else refer more patients than Dan did. And the reason that is so is because Dan recognized periodontal disease all the time. He was really looking for it. It's a tricky thing to find sometimes. Maybe one day I'll get up and I'll show you some slides and show you what you should be looking for in your own mouths and the mouths of your grandchildren and the relatives, just to note something to people so that they're aware if they have it or not. But that's aside from the point today. I just want to say that it's been a pleasure working with Dan. He's one of the most fabulous dentists that I know, and I say that with all my heart because I know what a good dentist is. So, anyhow, Dan Olsen, I'm not going to say Dr. Dan Olsen, but Dr. Dan Olsen.
I won't take the podium away from you.
You've heard it. No, you've heard it.
Away.
We'll get out of your way.
You've heard it. They kind of get used to it up here.
We'll be over here if you do this.
By the way, I met Murray in 1973 when the day he was inducted into Rotary.
That's right.
That's how I met him.
That's right.
I had heard about this guy who was opening a perio practice in Lexington because one of my colleagues in my building was a periodontist, and he was very upset about that. So I didn't even know what your name was. I just heard about this guy on Huzzy Street. So I got to credit Rotary with Murray and I meeting each other. But I'm going to talk a little bit about what has changed in my profession over the years. I've been in dentistry for over 50 years now. I've been in Rotary for 48 years. I can't believe that. But it's before I start talking about that, I want to tell you a funny thing happened to me this past week. I had a patient walk into my office. I won't tell you what his name is because some of you might know this person. But he said, "Doc, I have a bridge that broke in my mouth and I need to have a new bridge made." So I did my exam and had a little conference with him, and I said, "Well, I have some bad news for you." "What?" He says, "Well, go ahead." I said, "I agree. First of all, I agree that you need to have a new bridge, but you don't need to just have a bridge. You need to have a whole highway of teeth done." You don't get it. Okay.
Bridge, highway. Oh, we got it.
Bridge, highway. A highway's real long.
We got it. We got it. Thanks.
That's good.
Wake up.
That's why you're an excellent dentist.
Then I had another patient came in,
Oh,
and he was sitting in my chair and sweating bullets, and he was so nervous. It wasn't unbelievable. I was wondering if I was going to get to first base with this guy. And I said to him, "Okay, sir, will it be Novocaine or guts?" And he says, "Dr. Olsen, I don't even have the guts for Novocaine." Anyway, that being said, when I graduated from dental school, let's put it this way, my father was a dentist. He graduated in 1932. We have, to date, 9 dentists in my father's family. A number of them have passed away, but my grandnephew is going to be number 10. He's a dental student down at Virginia Commonwealth Dental School. But what I learned in dental school and what my father learned in dental school wasn't that different. The things they were teaching back then, they were still teaching when I went to school. I graduated in 1969. It's so different now. What I learned in dental school versus what graduates today are learning is a world of difference. There is unbelievable things, and it's not just in my profession, it's in probably everybody's profession. But I'm here to talk about mine. The big thing, one of the that's made all the difference is computers. I put my first office computer in 1983 when people were out buying Apple IIs and stuff like that. I put an office computer. I was the second dentist in Lexington to put a computer in my office. And I quickly became dependent upon that computer for billing and record keeping for patients. Very simple stuff. But computers have impacted every area of dentistry. That's one thing that has been unbelievable. With record keeping, email, obviously, we email x-rays to other dentists. We don't send hard copies or original x-rays to anyone anymore. And record keeping, as far as billing goes, clinical charting, especially in periodontics, you can chart pockets with a computer now. There's a little device that goes under the gum that measures the depths of the pockets around teeth. So that's been a big thing. The other big thing that has changed everybody in dentistry is in the area of radiology and x-ray. Digital x-rays have revolutionized x-ray taking. It's minimized the amount of x-ray that people are exposed to. It allows x-rays to be put instantly into a patient's record, and results in the sensors that we use are so sensitive that it's cut down the exposure to x-rays by about over 50%, so the exposure to x-ray is lessened for patients. And we've also got new three-dimensional x-rays. Cone beam technology is really taking off, where you can have one x-ray taken and the doctor can see 3 dimensions. Can't just see 2 dimensions. Typical x-ray that's taken is only 2-dimensional, height and width. But there's a 3-dimensional object that we're taking a picture of. Now we can view these things 3-dimensionally, and it has changed every aspect of dentistry like you wouldn't believe. And my office is basically what we call a restorative office, where we do fillings and crowns and some bridges and dentures and stuff like that. Things that replace the teeth or repair the teeth.
Don't forget highways.
And I made a lot of those. Not so much anymore. I'll get to that in a minute. One of the big things in restorative dentistry that's happened since I've been in it is what we call the acid etch technique, or bonding. We call bonding. I don't know if anybody's not familiar with that, where we etch the surface of the enamel on the teeth, and we can actually attach resin materials, acrylic materials to the teeth, and it has changed dentistry like you wouldn't believe. And I'm very proud to say that I was one of the very first dentists in the country to learn about bonding. I was employed at the University of Buffalo Dental School in the Department of Operative Dentistry when I graduated from the University of Buffalo. And we had, in that summer, my first summer of being there, we had a staff meeting at Operative Dentistry. Operative Dentistry is the part of dentistry that does fillings and inlays and stuff like that. And this dentist named Dr. Michael Buonacore from Eastman Dental Dispensary in Rochester came to the University of Buffalo Dental School and demonstrated something he discovered called acid etching, where he could etch the surface of the enamel and apply a resin material to it, and it would cling to the surface. This changed so much in dentistry. It was unbelievable. We were the first ones that were told about this. I was in charge of the emergency clinic at the time at the school, because it was the summertime and the students weren't there, so the low-lifes on the faculty had to take care of the emergency clinic. And that day, I did a procedure that I could not have done without doing that technique. And we didn't have composite resins, but we used unfilled resins back then. I think Murray and Don probably know what we're talking about. Severtron we used, which was a very popular resin. And I restored the patient's tooth with that. The patient was absolutely delighted. I couldn't have fixed the tooth any other way, just having learned that. So that's a huge thing that happened. The development of tooth-colored filling materials, composite resins, came along very shortly after that. And make a long long story short, it has resulted in a huge decrease in the use of silver fillings in dentistry. Very few dentists are doing silver fillings or amalgam fillings. Plus, there is increasing evidence out there, although it is not scientifically proved yet, that the mercury in your fillings can have negative effects on your health. It's the American Dental Association. What?
I knew it.
You know it, yeah, okay.
I'm getting rid of them all.
Oh, come on in, we'll do it. But it's a very controversial subject, and I don't want to get into it right now, but just to let you know, I haven't done a silver filling in 21 years. So, and resin materials have taken over for it. We've also got the use of zirconia in dentistry. Now zirconia is like what they make the fake diamonds out of, cubic zirconia. Very, very hard, just like a diamond. And you can't tell a really good quality cubic zirconia without an electronic instrument, apart from a diamond. But zirconia has pretty much replaced the use of gold. I mean, if we're going to make a crown for somebody who has a heavy bite, we can make it out of zirconia. It's tooth colored, it looks nice, and they can't break it. We had on YouTube, there was a demonstration of a zirconia crown and an all porcelain crown. And to show you how strong the zirconia was, and identical shapes, they put the crowns down with the base of the crown on a 2x4. And they hit the porcelain crown with a hammer, and it just turned into powder. It was gone. They hit the zirconia crown with a hammer and drove it down into the wood where you couldn't remove it. And we tried that in my office. I have a little place in my office where there's an exposed 2x4. Yeah, and the same thing happened, and that zirconia crown's still stuck in there. We can't get it out. So it's an incredible material. It's made a tremendous impact in dentistry. The other thing in restorative dentistry is one of my favorites is the CAD/CAM system, where if you have to, used to be in previous times, if you had to have a crown or a cap or an inlay made for your tooth, you came in, you had the tooth prepared, the dentist had to take an impression of it, they had to make a temporary crown for you, send it to the lab, you had to wait a couple of weeks, come back from the lab, the dentist tries it in. If there's something wrong with it or it didn't turn out quite right, they might have to send it back to be adjusted, or sometimes they'd have to take another impression and send it back and have it remade. So it was a minimum of 2 appointments, sometimes 3 appointments, sometimes more. Now we have a system where you need to have a crown or an inlay done. You can even have, in certain practices, you can have the bridges made this way. You come in, you have your tooth prepared, the dentist takes a picture of it with a computer, and it comes up on the preparation, the tooth comes up on the screen, and the computer designs the restoration for us. We tweak it a little bit just so that we can have a little fun. And push a button, and it signals a milling machine in the next room, and it will cut the crown or the restoration while the patient waits. It takes about 18 minutes. Take it out of the machine, you bring it back to the patient, fit it in the mouth, cement it, and the patient's done. 1 appointment. Huge, huge advance in dentistry. It was invented in 1987 by a dentist by the name of Werner Morman, and I remember the Lexington Study Club had a demonstration of that original CAD/CAM system, and it was, all they could make back then were tiny little inlays that we could easily, teeth that we could easily restore with a film. And the system cost $250,000 back then. Now everybody thought Morman was crazy, but he kept going and going and going, and he kept developing it and developing and developing it. And now it has become very, very popular. I have other companies that have copied the technology, and it's growing and growing. When I put my system in 15 years ago, there were about 5% of the dentists in the country were using. Now it's risen to about 10%, so it's growing very quickly. And the area of prosthetics, which is, prosthetics means a replacement of body parts. In dentistry, it's a replacement of missing teeth. Used to be that the best way to replace a missing tooth was to make a bridge. You prepare teeth on either side of the space for crowns. It means you taper them down, you cut them down, take an impression of it, and the bridge is made up of 2 crowns and a replacement tooth that's attached to them. So that means the patient has to sacrifice the teeth on either side to hold the bridge in. We also had to do highways of teeth, bridges that went all the way around. Patients that Murray and I did a lot of these cases together. We called full arch reconstruction or perio prostheses, where patients had periodontal disease and they had several missing teeth that had to be that couldn't be saved. We had to take out the bad teeth and then make bridge work all the way around to replace those teeth. And it was a huge project. It took probably a couple of years before the patient had the bridge work done, from the start of the perio to the end. It was a lot of work. Now we have something called implants. And implants is one of the huge breakthroughs in dentistry. When I was in dental school and while I was teaching, we had a research team that was looking for ways of creating implants. And every material they made implants out of failed. You put an implant in, you had to tell the patient it was only going to probably last about 2 years, and then it would have to be removed in some other way of replacing the teeth. But in 1965, Dr. Brannemark in Europe, who was a orthopedic surgeon, was looking for a way of pinning bones together, fractures. They were using stainless steel pins. You broke a bone, they put the pins in to hold the bone together, but then when the bone healed, they had to go back in and remove those pins. The surgery to remove the pins was probably worse than the break in the bone to begin with. I mean, it was a major, major procedure. And he was looking for some material that they could use where they didn't have to remove those pins. And one of his technicians that was working for him made up some titanium pins. And he was doing his research on monkeys. So he put some titanium pins in the monkey, and 6 months later, went back in to try to remove them, and he couldn't remove them. They took x-rays of the case, and they found that there was no space between the pins and the bone in the monkey. And he developed what's called osseointegration, or bone joining bone. The human body does not recognize titanium as a foreign substance. And out of this has grown the replacement of knees and hips. I remember way back in around 1989-90, watching on TV on Sunday morning, they used to show surgeries. You could watch a whole surgical procedure done. And I watched a hip being replaced. And it was exactly the same kind of procedure that we use when we do an implant in the mouth, but just on a bigger scale. And so Brannemark introduced the first dental implants in 1965. United States FDA allowed them in this country in 1985. We essentially used the Europeans as experimental subjects. When their 20-year studies came in with like 95% success rate after 20 years, 95% of the implants that they put in 20 years prior to that were still there. We can't give anybody a 20-year predictability on any of their teeth in their mouth. You just don't know what can happen. So it has become an extremely beneficial thing for patients, because now the person that was going to have the big highway of teeth done can have those bad teeth removed and have them replaced with implants. So so you don't have to make a big long bridge going all the way around. You keep the healthy teeth, get rid of the bad teeth, and replace them with implants. And that is, in prosthetics, the biggest breakthrough in my time. Also, we have what we call flexible partial dentures now. These are devices that replace part of your teeth, and you can take them out every day when you go to sleep at night and clean them and put them back in. They traditionally are made out of a metal framework with an acrylic section that holds the teeth in place. But now we can make them out of a flexible acrylic type material. And it really, I think, is better for the patient than one with metal clasp on it, because of the flexibility, it takes a lot of the stress off the remaining teeth. And it's much more comfortable for the patients. And then also we are using ceramics like you wouldn't believe in prosthetic dentistry. I mean, ceramic materials are replacing most of the metals that we use in dentistry. In the area of periodontics, which Murray should probably talk about this more than me.
Not today.
Not today. I only have 4 more pages, Dan. Back when I went to school, they were teaching us basic perio. There wasn't anything about bone grafting or much said about that back then, because you lose the bone is gone forever. And the problem was you didn't want the patient to lose so much bone because of the disease that they would no longer have enough bone left to support a denture when the teeth are lost. So it was a real problem. Now, periodontists can restore the bone that was lost by bone grafting, provided everything else falls into place. There also is a lot of soft tissue grafting being done. You hear the old expression, oh, you've got a little long in the tooth. Well, that's because in previous times, people's teeth looked longer because their gums and their bone were shrinking. And then you wind up, somebody would smile and you'd see the roots of their teeth showing. Now it's not necessary for that to happen, because they have techniques where they can actually graft gum tissue onto this root surface and improve the aesthetics and improve the function and the what we call maintainability of the mouth, where the patient can keep things clean. Of course, implants have made a huge impression in periodontic treatment also. Just about every periodontist out there does implants as part of their practice. And the other thing in perio is that there's been an increased public awareness of this disease. When I went into practice, just about every adult patient came through the door had periodontal disease. I mean, we were unbelievable the number of people that had periodontal disease. Now you have new patients come in, and they're more educated. They're more aware of the problem with gum disease and how it can destroy your teeth. And people's oral hygiene is better because of that. And I've seen a huge difference. Far fewer patients have to be referred out for periodontal disease than there used to be. And as a result, we've seen a reduction in the incidence of perio. In the area of endodontics or root canals, probably the scariest thing you can tell a patient is they need to have a root canal. That sounds like pure torture. Not anymore. Root canal techniques now are so streamlined. They use microscopes to examine the inside of these teeth. They can find a lot of things that we couldn't see by the naked eye. They also have automated instrumentation now, where if you have to have a molar root canal done, you can usually have it done in one appointment. It used to take 4 or 5 appointments to do because it was such a difficult procedure to do. And of course, 3D x-rays have made a huge difference. The endodontist now can look at your teeth and find things we couldn't find before. They find multiple canals. Some roots that only have 1 canal, they might have 2 canals. But you can't find them on a regular x-ray. You have to have a three-dimensional x-ray. Oral surgery, implants are huge in oral surgery, bone grafting. Sedation techniques for patients who are going to have teeth extracted are so much safer now. You have conscious sedation. You don't have to anesthetize a patient. Conscious sedation means your oral surgeon can give the patient an injection. The patient will be awake, but they're not going to be aware of it, that they're awake, and they won't be aware of anything that's going on. And when it wears off, a few minutes after the procedure, the patient feels fine. They don't feel sick for a day. And of course, the 3D x-rays in oral surgery are extremely important part of that specialty. Just a couple of other things. Pediatric dentistry. You thought I was going to leave you out over there, huh? The biggest thing that's happened in pedo, is fluorides. I mean, the fluoride in the water and the fluoride in the toothpaste have made a huge change in dentistry. When I went into dentistry, kids would come in, maybe not so much in Buffalo, but when I moved here, because the water was not fluoridated in 1973. It wasn't until much later in the 70s that the Boston area water was fluoridated. Kids would come in, they'd have cavities all over the place. Adults would have cavities all over the place. A lot of that has changed. I mean, the difference that fluoride has made is incredible. It is the most effective public health measure ever undertaken. I mean, you think smallpox is great, and polio and all that stuff, but as far as anything something that benefits the most people in the country, has been fluoridation. The other big thing in pediatric dentistry is pit and fissure sealants. Now the dentist can go in when the teeth erupt into the mouth. Teeth have little grooves and indentations in the surface, and many times these little grooves are not formed completely, and that's what can lead to decay. And we can seal these with resin materials and the bonding materials so that they don't decay. And it's been a huge, huge advance in pediatric dentistry. Now I want to take just a couple of other things. The microbiology research that's been done in dentistry is incredible. They have identified over 800 different microorganisms, different bacteria type organisms in the average human mouth. Over 800 different kinds. Resulting in the human mouth at any given time, there are over 800 trillion microorganisms in the average human mouth. That's more than every sand on every beach in the world. Every grain of sand doesn't even come close to that. So it's a very challenging area to deal with as far as dentistry goes. I mean, it's probably the dirtiest place on the planet. Another thing I want to talk about a little bit is they have recently shown that patients who have periodontal disease are at risk for developing other systemic diseases. Periodontal disease has been linked to heart disease, Alzheimer's, osteoporosis, lung disease, certain cancer risks, namely pancreatic cancer, kidney problems, and blood cancers, primarily leukemia, and diabetes. For a long time we thought that any diseases in the mouth did not have an effect on the rest of the human body, and that we weren't too concerned about that. But more and more studies are showing that people especially with periodontal disease, run the risk of having a much tougher time dealing with these other diseases. Now, what the future holds for dentistry, just a couple things. Improved lasers. Lasers are being used in dentistry. They're developing lasers now that can cut hard tissue so that we don't have to use a high-speed drill so much anymore. They still don't have a laser that can take out an old filling, like a silver filling or a composite resin. You can't cut those with a laser yet, but they're working on that. The other thing is stem cells to replace lost teeth. a lot of research going on where certain types of cells can be deposited in the socket when a tooth is extracted, and a new tooth will grow. They're showing this in animals, and they're working on doing it in humans. And just as an aside, they're coming up very soon, and probably going to have it within a very short amount of time, needle-free anesthetics, where you can have an injection of Novocaine or another anesthetic without having to have a needle. So these are just some of the things that were different. It happened during my time in dentistry, and it's created an absolutely, unbelievably exciting profession to be